Good afternoon, everyone, and a huge welcome to you, supporters and friends of the British Heart Foundation, to our online event. My name is Dr. Charmaine Griffiths, and it's my privilege to be the Chief Exec of the British Heart Foundation, and I hope this finds you and yours well this afternoon. We've got a great session lined up for you. We're going to be hearing more from some of our colleagues and amazing researchers about the work that we have, the research we're undertaking in light of COVID-19, and also some of the latest advances. So I hope you enjoy it. I look forward to hearing from you as well in the sidebar with questions. So we've already had some brilliant questions. If there are things that interest you or you'd like to hear more about, then please do get in touch using the question facility. So before I perhaps open up, I might just tell you a little bit about what's been happening in the British Heart Foundation over recent months. Clearly, this is a time of huge personal as well as professional disruption for so many people. I really do hope that you and your family are well at this point. So it's my privilege to return to the British Heart Foundation in February this year, and I have to say I've just been overwhelmed with the amazing support of all of our donors, supporters and volunteers, as well as our British Heart Foundation team, in the face of such an enormous health as well as financial crisis that the pandemic has posed. We have such an amazing team and amazing supporters, and you're a huge part of that. So thank you to everybody who plays their part in supporting the BHF and its life-saving work. And I hope that you'll be inspired this afternoon, as I am, by hearing a bit more about our research activities. But before we come to that, I was just going to pull out a few things that are really important that have happened within the BHF over recent months to share with you in case they're useful to you and your family or your loved ones, but also just to give a sense of some of the things that we are working with. So clearly the pandemic has been, like for so many organisations, incredibly devastating. From mid-March, we had to close all of our retail shops and stores on high streets across the country and cancel much-loved fundraising events. And the team behind the scenes at the BHF have been working really hard to ensure that we get ready to reopen. I'm really delighted to see over 700 of our shops and stores are open this week on high streets across the UK. So if, like me, you've had a good declutter in the lockdown, I'd really encourage you to take your stock and donation along to your local store. One thing also I'd like to share with you that we've done during the COVID-19 crisis is recognising that people with heart and circulatory disease are sadly more significantly affected by the pandemic and the virus than others. The BHF has put in place an amazing suite of resources to support people who need us most. So we've got this great coronavirus hub online that provides amazing information, support, and also directs peer-to-peer support so we can connect people. Many of you may have seen it already. If you haven't, I'd really encourage you to go and have a look with that at the resource and share that with your loved ones in case it's of use to them as well. So clearly it's been a challenging time, and the team are doing an amazing job at the moment to help us mitigate the huge financial impact of the COVID-19 crisis. We've already said publicly that we anticipate our net income in this year is going to fall by roughly half. And as a consequence, that really threatens our pipeline of research investment for new research. And so we're working really hard to not only fundraise ourselves and look for innovative ways in which we can support our activity going forward, but also to lobby government and others in order to try and gain support for our life-saving research and other activities. So there's lots of, I can assure you, so much happening within the BHF to try and protect this amazing life-saving work that I know matters to you as much as it does to us. So with that in mind, I'm going to hand over to my colleague and our Medical Director, Professor Nilesh Samani, perhaps to introduce a little bit more about what the BHF has been doing in research terms to help play our part in tackling COVID-19. So over to you, Nilesh.
Thank you, Charmaine, and my welcome to all of you as well. Charmaine, I thought what I would do is to cover two things this afternoon. The first is to speak to you about what the impact COVID-19 has had on our research and what we're trying to mitigate, how we're trying to mitigate the impact. And secondly, to also describe some of the exciting research that we're doing on COVID-19 itself and its impact on cardiovascular health. So I'll split my presentation into those two aspects. So, as I'm sure many of you know, over the last few months, research largely has come to a halt in many ways because universities are shut. The NHS has clearly moved back towards focusing on preparing ourselves for the pandemic and supporting the clinical service. And we are very proud of the BHF that many of the clinical researchers we fund have moved towards providing frontline care during this period. And many of the scientists we fund have taken part both in research, which I'll describe in a minute, but also in the testing capacity that the UK have developed. So we are we're very proud of the contribution that BHF-funded researchers have made regarding COVID-19. But as Charmaine has just said, this has had a huge impact on our ability to fund research. Our first priority in this situation was, of course, to make sure that the research we are currently funding, and we have currently about £450 million of investment in research in the UK, and we support over 1,700 researchers directly, and many PhD students. Our first priority was, of course, to protect that research. And so because of the pause and the things now beginning to start, we set up a number of different ways that we are going to continue to support that research. So we're looking at all the clinical trials we fund and see how we can revive them and make sure that they go to completion, because it's really on the basis of clinical trial evidence that many of the treatments are provided for patients. We've also put an imaginative scheme. I mean, one of the groups of people we are particularly concerned about is our early career researchers. We fund a lot of PhD students or early career researchers, and the effect of the shutdown on them has been quite profound. So we agreed a scheme with universities around extending the contracts or the stipends of these students for longer so they can complete their research successfully. We also put in a scheme for researchers to ask for additional funding for us again to complete their projects. It's really the new research that we have concerns about and where we need your support most, because as Charmaine said, our income is going to halve this year, and this is going to have a very significant impact on the research we fund. We already fund the highest quality research in the UK by many means, and having the income cut and the amount of research funding we have reduced as a consequence of the pandemic, we are having to draw the bar even higher than we normally do in terms of research we fund, and we would like, obviously, your help in trying to mitigate that effect. So I hope I've given you some feel of some of the things that we've done in terms of protecting the research we currently fund, and our wish, obviously, desire, despite the pandemic, to continue to support new research over the next few years with your support. What I want to do next is to just turn to our contribution on the research front to COVID-19. Soon after the pandemic started, we recognized, of course, that COVID-19 was not only a respiratory illness, but an illness affected the whole body, and particularly affected the cardiovascular system, the heart and the circulatory system. And therefore, it's very relevant to the BHF that it impacts on patients that we particularly serve. So to try and galvanize research efforts in this area, what we've done is we set out a national call around flagship projects that we wanted to fund across the United Kingdom on COVID-19. So what we wanted to do was to make sure that the research community come together and hold around some specific projects that they can all contribute to on a national basis to make those projects particularly impactful and will provide the benefit that patients require. So currently, if you go to our website, you'll see details of these projects, but we're currently supporting 6 such flagship projects, which cover the full dimension of the impact of COVID-19 on patients with cardiovascular health. So the 3 things the projects are trying to first learn is why are people with cardiovascular diseases, as I'm sure many of you have heard, people with high blood pressure or diabetes, why are they more susceptible to risk of COVID-19? This is, as I said, an illness that starts in the lungs, but the people who seem to be most susceptible are people who who have cardiovascular diseases. Why is that the case? We need to understand that. The second thing we need to understand, and our guest speaker this afternoon will speak to some extent about this, is what is the impact of COVID-19 on the heart and the circulatory system? In what different ways does COVID-19 affect the heart? And I'm sure in the questions we have, we'll touch on some of those things this afternoon. The third area that we need to also understand is the impact that some of you have seen that COVID-19, the pandemic, has had on the routine care of people with heart and circulatory diseases. Many operations have been paused. Surgery treatments in hospital have been paused. Some of the screening programs have been paused. Now, those will have a toll, and we need to learn about that, and so that we can mitigate that impact in the medium term. And finally, a couple of the flagship projects that we are supporting are beginning to start looking at the longer term effect of COVID-19. So there's the acute effect that patients suffer with, but there's likely to be, it's beginning to emerge that there may be longer term effects of COVID-19, not only on the lungs, but on the heart. And we need to obviously understand that, hopefully during this first wave of the pandemic, so we can just start to say what are the treatments we can provide if this comes back in the second wave, so we can prevent those longer term effects happening. So the BHF is really very has a whole range of activities around COVID-19. I mean, you might have seen some of the emerging papers that have come out. One of our senior researchers in Edinburgh published the fact that whilst it may not be noticeable, COVID does have a significant impact in the heart, even if they don't have any symptoms from the heart. So this was published last week. We are beginning to understand some of the reasons why people, what some of the different aspects, there are some specific aspects by which COVID-19 affects the heart, which are not typical of the normal diseases we see. And hopefully the discussion will bring some of those out for you. So Charmaine, again, just to provide all of you, I hope I've given you a sort of range of things that the BHF is currently doing in this space. But really the important thing today is, of course, we have a lot of questions from you, and I hope that after the next speaker, we'll have a chance to discuss some of these things during the question period. So it's my pleasure really to introduce one of our BHF professors. The BHF has 31 current shareholders, so we fund people at different stages of career, and the pinnacle of that is, of course, having a British Heart Foundation funded chair, and we have 31 such professors at the moment, and one of them is Professor Federica Marelli-Berg, who is at Queen Mary University in London, and she is an immunologist by background, and this is obviously very relevant to the COVID-19 pandemic, because as many of you have heard, is vaccines and immune system and so on are relevant to this. So Federica, over to you now, and thank you for your presentation.
So hello. My name is Federica Marelli-Berg. Thank you, Nilesh, for the kind presentation. And as you've heard, I'm an immunologist, but I'm an immunologist very interested in the inflammation of the heart, so specifically of what happens to the heart when inflammation is happening. I'm going to tell you today about some research that we have been doing, and I believe it's been quite successful in what we found and what we have the potential to do. But first of all, I wanted to tell you a little bit about myself. So I was, sorry, this is gone. You probably gathered from the accent, I'm Italian. I was born in Milano, and I always had a real passion for nature. This is me at 2 years old, but also to be on a stage, and especially as here, my first nativity place, as the main character of the play, so baby Jesus here. I studied medicine in Milan, and I graduated with a thesis on how T lymphocytes, which are blood white cells, kill tumors. And after a number of things that I did in so many years, which I'm not going to tell you about because it will take probably an hour, and I like to talk about myself, I really reached the pinnacle of my career with the award of the BHF Chair of Cardiovascular Immunology. It wasn't easy, I promise you. This was the pinnacle of my professional career, but I think the bigger achievement is no. Sorry about this. Okay, I got there. the bigger achievement was to have my twin girls, my daughters, which gave me a lot of work to do. This is them a while ago, but also they gave me a lot of inspiration. And a specific episode that I would like to share with you is that at some point in primary school, they came home and told me that one of their schoolmates had a heart transplant, and what did it mean, having a heart that was from somebody else and all that. And I have to say that really got me thinking about what it is about heart transplant, what goes wrong, how difficult it is, how many people get it, and especially because I was an immunologist, how this heart transplant is rejected by the body unless a therapy is undertaken, and a very severe therapy, as I will tell you in a minute. So what I learned was that the heart is rejected by this very, very angry cell called effector T lymphocytes. Again, these are white blood cells, which are also very good sometimes to protect us against the virus. But they recognize the heart like a big bacterium that they want to get rid of, unfortunately. So what they do is they infiltrate the cardiac tissue, they enter via the vessels, and they destroy the heart parenchyma, so the graft is destroyed. We have drugs that are given to these patients, and I'm sure we're talking about COVID. You've heard that these patients with transplants are sheltering themselves, and they're particularly susceptible to the virus because of their immune status. So what is conventionally done in these people that receive a heart from a donor is that they give them drugs that wipe out completely the immune system. So the heart is not destroyed, however, because the immune system is not working anymore, not just by rejecting the heart, but also by fighting viruses and fighting infection and cancer itself. These people very often die of infections and cancer. And I felt at that time, when I was thinking about a 7-8 years old with a heart transplant, this is not good enough. So how can we change this? And this was, I think, the first of the program grant that I was lucky enough to get from the British Heart Foundation. So I thought of ways by which we could prevent the immune system, these T cells, nasty T cells, from attacking the heart while maintaining the heart as a whole, you know, maintaining the heart, but also the rest of the immune system. So leaving these patients with their transplant, but also capable of fighting infection. And so the first strategy that we thought of was to try and block the access of these nasty T cells to the heart. But in parallel, we also thought that maybe we could have harnessed another type of T cells which are present in our blood, in our circulation, which are called the regulatory T cells. These are the angels, because what they do is that once we have fought a virus or a bacterium, they come in and they tell to the effector T cells, stop it. That's enough, plenty. So maybe by increasing their migration to the heart, we could have saved the tissue by stopping the immune response, because these cells respond only to inflammation, so they wouldn't have attacked or, decreased other immune responses, which were normal. And the point was that we wanted exactly to protect the heart, but also to maintain the immune system functional to fight other diseases such as cancer and infections. So how did we do this? And that we try to understand how the T cells, the nasty T cells, get into the heart. And we know that cells use a navigation system, a kind of tom-tom that tells them which organ they have to do. And in 2015, we discovered the signals, the TOM-TOM code, the area code that T cells use to get into the heart. So we blocked these T cells, and I can tell you that in mice, blocking this area code prevented heart rejection, but maintained the transplants, prevented heart rejection, but allowed rejection of skin graft, showing that the immune system in these mice was maintained with the exception of the heart. Now, at that time, I also had the opportunity, because I moved to Queen Mary from Imperial College, I had the opportunity of meeting an incredibly talented cardiologist, Dr. Sam Moedin, who introduced me to a disease that I never thought about, but it is probably a lot more frequent and a lot more dangerous and unmanageable than heart disease. And this disease is, the heart transplantation. This disease is myocarditis. So myocarditis is a big black hole in cardiology, in that it's a condition in which the heart becomes inflamed, and we know as such, but we have very little understanding of how frequent it is, because the data, for example, show that when you hear about somebody running the marathon and suddenly drops dead because the heart stopped, well, 1 in 10 of these people, when they get the autoptic examination, the autopsy, has myocarditis that was not diagnosed before. So there is a problem on understanding how many people get this disease. But not only that, when you actually suspect this disease, and many GPs are not aware of this frequency, so maybe they don't think about it because it's very elusive, the presentation. The diagnosis is pretty, again, difficult, because there are very specialized scans that can give a hint that there might be inflammation in the heart, and this require very expensive examination and a specialization of the radiologists that look at them, but also we call it gold standard of diagnosis of myocarditis is a biopsy. And this inflammation of the heart is very patchy, so it's very easy to miss the area where the inflammation is. So this biopsy can give a lot of false negative. So now I'll tell you, the biopsy means that they put a catheter in the circulation, and they chop a little bit of heart muscle from muscle or tissue from the heart. And it has been shown that to have a 90% specificity and sensitivity of this test, you need to take 17 biopsies, which is nobody in the world does. So there is a problem there. On top of that, most of these patients recover. However, we don't know whether those that are not diagnosed, because the disease can be very mild and sometimes don't give symptoms, might end up presenting to their cardiologist a long time after with heart muscle disease, which means that the heart is not functioning properly because the inflammation has gone too far. So it's very difficult to tell these patients how they're going to do in the long term. And the final thing is the treatment. So what doctors do with this patient is that they try to keep the heart quiet, not to do too much work because it is inflamed, try to calm down a little bit the inflammation if it is very severe. But in some cases, if everything fails or the disease is too severe, they need a heart transplant. So we go back in the circle of heart transplant. And this is a very important point that I would like to put through to you as potential supporter of the British Heart Foundation. Now we hear about this disease occasionally. Unfortunately, we hear about it occasionally when some celebrity dies of it. And here, you know, I don't know, BGs, I don't know, the audience have to be very seasoned like me to remember, but George Michael was one of the celebrities that died of this disease 2 or 3 years ago. Now, I had the privilege and the honor to meet the parents of of these boys. These are young boys because the disease affects young men preferentially. These were very fit, very healthy, athletic, interested in sport boys that had the disease and unfortunately died of it. And I had the privilege to meet their families thanks to the British Heart Foundation publicity of my work. And we have established a fantastic relationship. And I have to say, they are not only inspiration, because as a parent, I can only imagine what they had been through, but they've turned a very tragic event, probably the worst thing a parent can go through, into a positive outcome. Because what they're doing is they are, I'm trying to, oh, I'm sorry. Oh, here it is. Sorry about this. It's slow. Okay. Maybe it's a big. Oh, finally. So these are they're here. The Thompsons, the Hughes, and the Parsons here together. We are celebrating the Accelerator Award from the British Heart Foundation, which is dedicated to understanding and curing heart inflammation. And these people, which I hope are amongst you, and I hope I give them enough credit, although I don't think anyone can do enough credit for them. They've been raising money and they do a lot of activity also for awareness of this disease. And so, you know, the research that I'm going to present to you again later on is also due to their immense and wonderful support and effort to raise money for the British Heart Foundation. And I have to say, as a researcher, for me, I love science. I love going to the lab, doing experiment, understanding nature, as I told you. But when this can translate into preventing this grief, for me, it's almost a life mission. So where are we so far? This is just an example of the tons and tons of data which we have gathered during this last few years. And we do hold meetings with these families to update them of our progress, which is great. We have found a way by which, by targeting migration of these effector T cells to the heart, we can prevent or ameliorate the inflammation of the heart, and hopefully this will become a therapy at some point. So here you can see this is a mouse model of myocarditis. You can see here this tissue is full of T cells, the nasty T cells that are killing the cardiac tissue. If we treat these mice with this drug, and this is done for a very short time, I'm sorry, I don't know what, oh, I apologize for this, it's my computer. If we treat them, the inflammation is a lot less. You can see that the heart is much more pink than this that is full of nasty lymphocytes. So we are on the right path, but we are even on a better path for another project that we have been running in parallel with this, and again, could be a new therapy for inflammation of the heart. So I told you about the nasty cells and the regulatory cells, the bad guys and the good guys. So what we have been trying to do, as you remember from my first slides, is to give an advantage to these slow-moving regulatory cells compared to the nasty guys, which tend to be faster and get to the transplant of the heart in myocarditis a lot more quickly. So what we discovered is a new drug in 2017, which can reverse the situation and make the regulatory cells much faster than the effector cells. Oh, I'm sorry, this is than the effector cells. And this has led to, we did a lot of experiments in animal model and so on and so forth, in which we have shown that we can actually prevent rejection as well as myocarditis in mice. But it was so, because this drug was already there, we didn't need to invent anything, it was there, we just did a little bit of science, we found that this could be a good thing to use, and it was easy because we didn't need to spend a lot of money to discover a new drug, but we took a drug that was already there and made it useful for a different type of disease. So I am delighted today to announce that we have started in March. This was then interrupted by the COVID problem, a clinical trial called ADOPT, in which we are giving this drug to patients which receive kidney transplants, and we did that because it's a lot easier to get enough numbers of patients to understand whether this drug is working or not. But in the context of COVID, we have also the Arcadia clinical trial, which is going to start in 2 weeks, in which we're going to use this drug to activate these regulatory cells to dampen down the excess inflammation in COVID patients, which seems to be one of the key causes of the problems that these patients have, especially when they need intensive care and ventilation. So this is a fantastic achievement for me. Hopefully these clinical trials will lead to the use of this drug in a GP context or certainly hospital context. So I think it was the last one, and the last one doesn't want to come through for whatever reason, whatever I'm doing. My computer, I think, has got the best of me. I'm not very good with IT. I'm very good with science, but IT is beyond me. So I just wanted to say, my last slide was with the heart inflamed, like the first one that you saw. I just want to say thank you, because to the Heart Foundation, British Heart, there it is. Thank you to the British Heart Foundation, because they trusted me, and they trust me on your behalf as donors. And we had this privilege to have the actual donors talking directly to us as scientists and understand and give us inspiration and motivation to do even more. That I love the science, but after I met these people, I love it twice as much, 100 times as much. And all the patients, the families, and everybody that has been involved in this work, and my lab especially, which is so enthusiastic and so committed to resolve this big problem. So I just have to say thank you, and I apologize for the computer thing. I mean, I need a new computer, clearly. Thank you.
Thank you, Federica, for such an inspiring update and also sharing a bit of your life and your passion with us. I'm aware that some of the people on the call might have had a few technical difficulties seeing your slides, so I don't think you're alone there in having a few technical issues. And I'd say to people, thank you for your patience in sticking with us. I could tell that your infectious enthusiasm for your work came through without them, but also know we'll publish the slides afterwards so you can catch up as well. So yes, thanks so much. That's absolutely brilliant to see, and hear you talk about the research and the importance of the British Heart Foundation in kind of funding it, and the supporters, many of whom on the call today will be obviously listening with interest. Also about your work with myocarditis, but also just thinking about the hope that you bring to other people and how that inspires you as one of our amazing scientists. It certainly inspires us at the BHF and gives us hope for the future too. So I know that we've had lots and lots of questions, so thank you to absolutely everyone who's put those through. We're going to take some time now to answer those. So you've got questions for Federica and also for Nilesh. So I might invite Christy to open us up with the first question.
Great, thanks, Charmaine. We've had some brilliant questions through. The first is for yourself, Charmaine. Has the BHF ever considered setting up the equivalent of Macmillan for cancer to help us find the help and support from different sources that we need at this time?
A great question. So we're really proud to work closely with our colleagues at Macmillan in lots of ways and in sharing information about what we think could help both people with both conditions, both cancer and heart and circulatory disease. I'd say actually we have some brilliant resources already online. I mentioned the Coronavirus Hub earlier, but that's just the tip of the iceberg. If you haven't already, please do check out bhf.org.uk and have a look at the wide range of support available for people. We particularly have an amazing heart helpline manned by specialist cardiac nurses that are a lifeline to so many people with questions and queries and have helped so many people through the last few months, in particular as people with heart and circulatory disease or risk factors or their loved ones have had concerns. So Christy, I would say please do, I'd encourage people on the line to check out the information and support that's available on our website. We know that over 2 million people have already had a look at the Coronavirus Hub and found the information and support there incredibly helpful. So I hope that many of you on the call today will have seen that already. If not, please do share it with your family and loved ones and people who might find it useful themselves.
Great, thank you, Charmaine. The next question is for Nilesh. So what have we learned about coronavirus and its impact on cardiovascular health, both for healthy individuals and those with pre-existing conditions? You're on mute, Nilesh.
Thank you, Christy. I think we're still learning, so I don't think all the answers are in yet, and that's why I mentioned the flagship projects. But some of the early things that we have learned about is one of the things that happens is what Federica just talked about, which is that there are people who develop inflammation of the heart as a consequence of the virus. So we're finding this in that sense a myocarditis. So that is one of the sort of damaging effects of the virus on the heart. But equally, perhaps equally important, if not more important, is the fact that we learned quite rapidly in the first few weeks after the virus started that if the virus makes the blood more prone to clotting, and the way it probably does it is by affecting the lining of the blood vessels. So it damages smoothing the lining of the blood vessels, and therefore when it's damaged like that, then the blood that's flowing past tends to clot at the side. As a consequence, you can get a heart attack, and often the heart attacks are not because the major arteries blocked off, but some of the small arteries in the heart are blocked off, and similarly you can get a stroke. And the third consequence of it is that you can get clots in the lungs. So people who are in hospitals and often immobile, they're more prone to getting clots in the lungs anyway. But the virus seems to make that even more intense. So very quickly we learned, we are beginning to learn some of the consequences of the virus on the heart. And almost immediately, one of the things that has emerged, which wasn't there in the first few weeks, is that many patients who now get into hospital with COVID-19 and who are particularly ill, we will certainly be treating with blood thinners or blood thinning medication as part of their treatment. Normally you wouldn't give for a virus infection, but blood thinning medication, and discharge them with blood thinning medication as a consequence to prevent the clots happening later. I've seen some rare cases, and I still do some practice in Leicester where people come in with rather peculiar things. Some people, the rhythm of the heart is disturbed. Some of them develop what's called heart block and need a pacemaker. So we are still learning some of the consequences of how COVID affects the heart. It seems to be sort of multifactorial. But the inflammation that Federica had mentioned and the sort of work she does is critical to trying to prevent that in the future. And the impact on clotting of the blood are two of the major things.
Great, thank you, Nilesh. Our third question is for Federica. So can babies be born with myocarditis? And if so, is there a way to prevent this? And is there a cure? You're on mute, Federica.
I try to be polite for once, and I mute myself all the time. Yes, it's a very good question, and children do develop myocarditis, babies do. One example is, for example, the rubella virus can give myocarditis that is transmitting from, the virus is transmitted from the mother to the baby. Now, the small children up to 2 years old do not do very well when they get it. So it's a severe disease, also because, again, it's very difficult to diagnose. The signs are very non-specific, and so again we go back to the awareness point that I was making before. After 2 years old, they're very similar to what you would find in a young adult. So they might have chest pain, heart attack in a 3-4 years old is a little bit of a surprise, and that's a problem with the differential diagnosis. So yes, the answer is yes. And again, we need, in my view, we have fantastic doctors, but sometimes they need to be reminded that some diseases that they never think about are not that rare. Because one of the big questions with children is that we don't know how many of these will come back to their cardiologist 20, 30 years later as relatively young adults with a heart failure that is not explainable and very often is due to a myocarditis that was never diagnosed in the first place. So thank you very much for your question.
Great, thank you, Federica. Our next question is for Nilesh. So how does coronavirus put people with underlying heart conditions at particular risk, which you've touched on slightly, but the second half of this question is, apart from following NHS guidelines, what other additional preventative measures can one take?
That's a great question. Well, both of those are great questions, really, and I don't have a full answer to either of them, to be frank. I mean, we're still learning why some people are more susceptible, whether different heart diseases have different susceptibilities. You often see mentioned in the papers, people with some risk factors like high blood pressure and diabetes at increased risk. I think, heart susceptibilities are so diverse, and people get affected to different degrees. So at the moment, this sort of general label of everybody with cardiovascular diseases or their risk factors are at high risk doesn't help very much for individuals, because we can't be more specific for them. So that is really a shortcoming of where we are at the moment. We know that some of these risk factors put you at increased risk, but which heart conditions are, whether if you had a heart attack in the past, you're at increased risk, versus if you have heart failure right now, you're at increased risk. We are still needing to learn, and that's one of the flagship projects is trying to do, is to provide that really granular information so we can tell people much more specifically about their own personal risk. Now, because of that lack of knowledge which we need to get, which we need to do through research, the answer to the second question is, what are the extra preventative measures we need to take specifically, is a difficult one, because we don't have those. So I think at the moment it really is around government guidelines in terms of saying that my advice to the patients that I see would be that, particularly those who have significant heart conditions, is to say you still need to take great care in terms of social distancing and so on. I think being very alert and vigilant is all you can offer at this stage until other treatments like vaccination and things like that come along. There are people doing research into specific treatments for people with heart failure who might get COVID-19. So we're seeing some research on that, but that is going to take some time. So I don't know who asked that question, but in honesty, we don't have the answers to those questions at the moment, and that's why research is so important.
Thank you, Nilesh. And a follow-on question from an individual who's anonymous. How will the BHF ensure that patients and the public are involved in a meaningful way in the research into COVID-19?
Terrific, another great question, and one we are very, very conscious of that. Most of what we want to do has to be led by patient, and patients help us in formulating the question. So each of the flagship projects we've got, and that's only part of the thing, but each of them have a strong patient and public involvement. So each of the teams, these are nationwide teams, where each of them have a patient and public involvement in their projects to guide both the questions that should be asked and also to help in terms of explaining the results to these people and then help them disseminate the findings. Some of the flagship projects are around data. So, one of the things that the UK is should be very proud of is that we've got fantastic data in our NHS, in the healthcare system. And we've set up a thing called the BHF Data Science Centers that some of our supporters might have heard of, particularly to use that sort of routinely collected health data to answer exactly the question I was just asked about, why are some people at increased risk? Use of that data is very sensitive, of course, because this is people's personal data. Although it's anonymized and providing the right framework, we still need to have the confidence of the public that we are using that data in the right way. So particularly those projects that have got data science or data related projects, we are very careful to make sure we involve the public so that the people who provide access to the data are aware that we are working on behalf of the public. So there's significant patient and public involvement, particularly in those data science projects.
Lovely, thank you, Nilesh. Our next question is for Federica, and it's one from John L. Dixon, who is with us today. So what level of routine monitoring should one expect having been diagnosed with hypertrophic cardiomyopathy? Should scans, angiograms, etc. be repeated at intervals? You're on mute, Federica. Still on mute.
My politeness again. So it's not exactly my field, but I think monitoring in this type of disease is absolutely crucial. And for every clinician, there are very serious guidelines that are followed by which they monitor these patients. So I think in this respect, you should trust your cardiologist. What I would like to add to this is that the British Heart Foundation has the ability to inform this type of monitoring that is carried out in clinical practice. So your contribution again and the research that is behind what is done at the BHF, it's incredibly important to perfect guidelines which are already very, very good in this country. I hope you answered your question.
Nilesh, please feel free to add. Thank you.
Yeah, thank you. Yeah, so thank you, Christian. Thank you, Federica. So I think this was obviously somebody either who suffers with hypertrophic cardiomyopathy or knows somebody with HCM. So that's a very specific inherited heart condition for those of you who are not aware. Hypertrophic cardiomyopathy comes in different shapes and forms in terms of the severity with which it affects people. So I think, again, this issue of how frequent monitoring should take place, certainly most patients who will be diagnosed with hypertrophic cardiomyopathy would at least, if they're very clinically stable, would be seen at least once a year and probably have their heart scans repeated once a year just to monitor them. So that would be the sort of standard practice for people who are very stable. I don't think there's a need for an angiogram in those people routinely unless they've got new symptoms that would suggest that an angiogram would be indicated. But clearly, as I said, some people are much more severely affected, and so those people may need much more regular monitoring. Some people with hypertrophic cardiomyopathy even need treatments like they have a defibrillator fitted because they might be prone to heart rhythm problems. So I think there is a sort of variation in terms of people's the severity with the condition that they're affected, and I think that guides to some extent how frequently they need to be monitored. But if you are stable, if you're relatively symptom-free from the hypertrophic cardiomyopathy, it's been picked up because you had a family history and you were found on a scan to have it, then once a year monitoring would normally be, and perhaps with an echocardiogram scan would be the routine practice.
Thank you, Nilesh. And a follow-on question for you, Nilesh. Has the intake of PhD students reduced as funding is affected by COVID-19? I know you touched on this, but it'd be great to expand.
So I think thank you for that question. So currently the BHF funds, several hundred PhD students. We fund them through a number of schemes. Our initial, as I said in my introductory talk, our main priority was to protect the ones we are currently funding. We are still continuing to fund new PhD students. Our ability to do so is going to be constrained by the income that we've got. One of the schemes we have is a 4-year PhD scheme, which 11 institutions currently in the UK participate in our 4-year PhD scheme, so 11 universities, and we allow them to appoint 4 PhD students per year. Now, and that costs us, over the course of the 4 years of these 4-year PhD students with 44 students each intake, about £25 million. So now our ability to fund the next round of those 4-year programs, which we need to do for next year, we have to think carefully in terms of the income we've got, and I think there may be an impact on this number of students we fund. The critical thing that the BHF and Charmaine has very strongly supported this is that early career researchers are a priority for the British Heart Foundation. We fund BHF professors like Federica, and she's fantastic at getting grants from us and others. We also need to protect the next generation of researchers, because if we have a gap of a few years where we don't fund this next generation, then we will have a whole, generation of researchers that we will lose to cardiovascular research, and we can ill afford to do that, given how prevalent cardiovascular disease is. So the BHF is giving great thought to how we protect that particular group of researchers and the work that they do, which is often very exciting. Mm-hmm. If there was a prospective PhD student asking me that question, I don't have a guarantee, but we're trying to do everything we can to protect them. Okay.
Thank you, Nilesh. Our next question is for Federica. What is the cause of inflammation in the body? Is inflammation a symptom of many diseases or illnesses, or a cause?
So this is an amazing question. Is the reason why somebody goes into research and stays for the rest of their life. Now, inflammation is a cause of disease, but what we are discovering, especially in cardiovascular diseases, is what is very important is what causes inflammation. So we are thinking about inflammation being caused by an infectious agent, but for example, in the obesity pandemic, we know that putting on weight itself can induce inflammation in the body. So what we need to understand is we know a lot about inflammation, but what we need to understand is how these things that are other than a virus or a bacteria can induce inflammation, and how that impacts the body. Because we know that people that have metabolic syndromes or obesity, diabetes, they have cardiovascular disease as a consequence of this imbalance and inflammation, as well as other things. So inflammation, I think, is an intermediate cause. That's what I would like to propose. I mean, maybe there will be an article tomorrow on this new theory. But in my view, it's important to understand what causes it in the first place when it's not evident. So I hope I answered your question. This is an existential question for a scientist, and I'm very grateful to you. It's very inspirational.
Thank you, Federica. That's great. Another question for Nilesh. If you have had a bypass or stents fitted, how much greater risk is there if you contract COVID-19, if we have this information currently?
Yeah, I don't think we have that information precisely. As I said earlier, I think it's fair to say I would probably put them at a slightly lower end of that risk spectrum. If you recovered well if you got coronary disease, but you recover, you had a stent put in, I don't think the stent itself is relevant to your risk as such. I think coronary artery disease has turned out to be a risk factor for high risk. If you've got coronary disease, you might suffer with high blood pressure or diabetes potentially, and so those have been identified as risk. So there is probably a multitude of things. But if you just have coronary disease and you had a stent fitted, and you don't have any of the other risk factors, I think the risk is perhaps elevated, but not so high. But we really do need answers. Precisely the sort of question you didn't answer to, in terms from the data science studies that we are trying to do through the BHF Data Science Centre.
Great, thank you. And we've had a question submitted during the talk, an anonymous question to you, Nilesh. With limited BHF funds this year and next, will the BHF continue to fund all their usual types of grants and fellowships, or will they put more of the available money into specific funding streams?
Thank you for for that question. I think what the decision we've made is that we'll keep all of our funding streams open at the moment. So those, some of you may be familiar that we fund all the way from laboratory science through to clinical trials. And we have 5 different sort of committees that consider grants of different types, from individual personal awards like fellowships, to clinical trials, to program grants, project grants, and what we call translation awards. We feel that the right thing to do is to signal that we'll keep all of those streams open, because they fund projects of different type and different scale and different impact. And what the main thing that will happen is the bar will go higher. When we got restricted funding, our ability to fund in any of those areas will be higher. But we thought it's important for people to still put their best ideas forward first, whichever scheme they feel it fits into. And then we'll choose what we think is the best out of those, rather than say we're going to stop funding project grants or we'll stop funding clinical trials, which we wouldn't want to do. Or the one thing I did emphasize earlier is that early career research are important for us, so we will try and give that some priority. But the important thing for us is to continue to receive the best quality application that people can put forward, and out of those, we'll choose the ones that we think have the best, I like to say, the best impact and are the best science. So we're not shutting anything down at the moment.
Thank you, Nilesh. And we have 4 minutes left. I have 2 questions, one for Federica, and then we'll finish with Charmaine. And just to let you all know that we will be publishing any of the questions that haven't been answered on our website after this session. So don't be afraid, we will have answers for you. So Federica, this one's for you. It's from Hazel and Gary Hughes, who are with us today.
Oh, gosh. Hello.
They ask, it has been great to hear from you, Federica. Please will you be able to update us on the progress of an early diagnostic test for myocarditis?
Yes, I love this question. I didn't have time to discuss this, but we, by discovering the area code of the T cells that the nasty guys that go and destroy the heart, we have been able to, we are trying to, well, we're preparing the paper, so we're pretty advanced in that. We have been able to correlate the presence of these cells in the peripheral blood compared to people that don't have myocarditis or people that have heart attacks, which sometimes can present in a very similar way to myocarditis. And what we hope to do, this is a very simple blood test, can be done in children because it's a little, we just need a little prick of blood. And we have been able to, we tested it in a clinical setting. We could do it in 20 minutes. So that's quicker than the troponin assay. And it's very, very specific for inflammation of the heart. So, watch this space. I'm hoping to get the paper out as soon as possible for you guys, because you've been a fantastic support. My best wishes to you, Gary and Hazel.
Thank you, Federica. And our last question to Charmaine. I want to know how I can support the BHF at this difficult time. What sorts of things can I do to help?
Oh, well, firstly, thank you. As we've described before, we simply can't do what we do and fund the research like you've heard from Federica and so many other scientists around the UK and the world without your support. And as you've heard, we need that support now more than ever. So if you are able to and willing, please do check out the sidebar, I think, of this conversation for a link to how you might be able to support and donate, or indeed have a look on our website. And thank you again. We simply rely on all of you amazing supporters of our volunteers and everybody in their different ways who comes to the BHF to help us and our life-saving work, and you have our heartfelt thanks for that, and we need you now more than ever. I know that you'll join me this afternoon in thanking both Federica and Nilesh for a really insightful and brilliant kind of talks and presentations. Please trust the slides, and the recording will be online, so if you joined late or had trouble seeing the slides, you have plenty of opportunity to see them afterwards, but I know you're joining me in offering our thanks to them for it. And I was going to say thank you to you for such brilliant questions. You've given our scientists a bit of a run for their money as well. I mean, my goodness, that's wonderful to see. And the thoughtfulness of questions is great. I know a lot of the questions that came up were about people's personal conditions, and with 7.4 million people in the country living with heart and circulatory disease, no wonder. I would just emphasise our website is an amazing resource with lots more information on it, and our coronavirus hub is just brilliant. So if you do still have questions, go and check that out, and please do share it with loved ones. It could help as well. So just to draw us to a close, thank you for joining us. We really want to hear how you found this. We'd love to hear what you found useful about this and would like to see again, and things you think we might be able to build on as we start to think more about how we use different forums to engage with our brilliant supporters. So we hope you'll join us for our next event. So please put in your diaries for the 26th of August, and I look forward to that. And please do tell your friends and family and other people you think might be interested, and we'd really welcome them joining us for this session. So lastly, one last check, if you haven't signed up for these events, there's a wonderful little link on our website at bhf.org.uk/public events. And you can sign up there to hear more about what's going on and register for future events, so please do that as well. But otherwise, I thank you for your ongoing support and very much for joining us this afternoon. I hope you've enjoyed it as much as we have, and take care.